What if I told you that the key to effective addiction treatment isn't just about the patient's willpower, but about understanding motivation as a dynamic interpersonal process? That screening tools like CAGE are just the tip of the iceberg in a complex web of assessment, withdrawal management, and therapeutic engagement?
Really, that's a powerful way to put it. I mean, we often think of addiction as a personal failing or just a matter of will. But framing motivation as something interactive and evolving, that changes the whole approach.
Exactly. And the stakes here are huge. Misunderstanding addiction leads to ineffective care, wasted resources, and poor outcomes for patients. But if clinicians grasp the nuanced tools and psychological models, they can better identify, treat, and support patients, improving recovery rates and reducing harm.
So by the end of this episode, listeners will have a deeper understanding of clinical screening tools, withdrawal assessments, psychological models of behavior change, and harm reduction strategies that are reshaping addiction care. That's a lot to cover, but it's essential.
Absolutely. Let's start with something deceptively simple but clinically valuable, the CAGE screening tool.
Ah, yes, the classic CAGE. 4 questions, right? Cut down, annoyed, guilty, eye-opener.
Right. It's a mnemonic for those 4 quick screening questions targeting substance use problems. Each yes answer scores 1 point, and a total of 2 or more indicates clinical significance.
What I appreciate about CAGE is its simplicity. It's quick, easy to remember, and practical in busy clinical settings like emergency departments or primary care.
True, but that simplicity is also its limitation. It relies heavily on patient self-report, which isn't always reliable. If a patient is unable or unwilling to respond, clinicians need to look for observable signs.
Like dilated or constricted pupils, abnormal vital signs, needle marks, tremors, or even the smell of alcohol on the breath.
Exactly. And collateral information from family or friends can be invaluable when direct assessment isn't possible.
So CAGE is a screening tool, not a diagnostic instrument. It flags patients who need further assessment but doesn't provide a definitive diagnosis.
That's a critical point. It's a first step, a quick flag to say, hey, we need to look deeper here.
I think it's important to emphasize the clinical judgment needed when patients can't self-report. Observing physical signs and gathering collateral history can make or break the assessment.
Definitely. And that leads us naturally into withdrawal assessment tools, which are more objective and guide treatment decisions. Let's talk about CIWA-Ar first.
The Clinical Institute Withdrawal Assessment for Alcohol, revised. It's designed to objectively assess the severity of alcohol withdrawal symptoms and guide benzodiazepine treatment.
Right. The goal is to prevent both undertreatment, which risks seizures and delirium tremens, and overtreatment, which can cause oversedation.
Withdrawal symptoms typically begin within hours of the last drink and peak around 24 to 48 hours. Severity correlates with the amount and duration of alcohol use, and older adults tend to have more severe symptoms.
And delirium tremens, or DTs, is a medical emergency with about 20% mortality if untreated. So careful monitoring is essential.
Nursing considerations go beyond just medication. Environmental support is key. Quiet surroundings, frequent orientation to time and place, and limiting visitors to one family member or friend at a time to reduce overstimulation.
The therapeutic approach is equally important. Non-judgmental, validating, supportive. Nurses need to manage illusions or misperceptions gently, clarifying them to reduce terror.
Like telling a patient, see, those aren't ants, it's just the wallpaper pattern. That kind of reassurance can make a huge difference.
And managing hostility or argumentative behavior with empathy, rather than confrontation, helps maintain a therapeutic relationship.
What about red flags? Global confusion, high fever, autonomic instability like hypertension and tachycardia, severe hallucinations. These all signal progression to delirium tremens.
Exactly. Immediate medical attention is required in those cases.
Now, shifting to opioid withdrawal, the Clinical Opiate Withdrawal Scale, or CIWS, serves a similar purpose.
Yes, CIWS is a standardized tool to assess opioid withdrawal severity and guide treatment decisions, especially during buprenorphine or naloxone induction, detox programs, and methadone maintenance.
It measures a range of symptoms: pulse rate, sweating, restlessness, pupil size, bone or joint aches, runny nose, gastrointestinal upset, tremor, yawning, anxiety, and gooseflesh skin.
The scoring ranges from less than 5, indicating no withdrawal, up to over 36, which is severe withdrawal.
Clinically, it helps balance the risk of undertreatment, which leaves patients in distress, and overtreatment, which can cause sedation or other complications.
Nursing care involves providing supportive, non-judgmental care, recognizing that withdrawal is physically painful and distressing, and collaborating with the healthcare team for appropriate pharmacological interventions.
It's interesting how CIWA-Ar and COWS parallel each other in their purpose and approach, tailored to different substances, but both aiming to guide safe, effective withdrawal management.
That's a great point. Both tools help clinicians walk the fine line between too little and too much intervention.
Now, stimulant withdrawal presents a different challenge altogether.
Right. Unlike alcohol and opioids, there are no proven pharmacological treatments for stimulant withdrawal, particularly cocaine and methamphetamine.
Cocaine withdrawal unfolds in 3 phases. The crash phase lasts up to 4 days and is marked by depression, anergia, agitated depression, peak craving, anxiety, and paranoia.
Then comes the dysphoria and anhedonia phase, which can last up to 10 weeks. Patients experience lack of motivation, intense cravings, and are at high risk for relapse.
Finally, the intermittent craving phase can last indefinitely, with occasional cravings persisting.
Neurochemically, cocaine blocks the reuptake of norepinephrine, dopamine, and serotonin, causing neurotransmitter imbalances that underlie these withdrawal symptoms.
Methamphetamine has a longer duration of action, 4 to 6 hours compared to cocaine's 20 to 30 minutes, and increases dopamine, serotonin, and norepinephrine, leading to alertness and euphoria, but also psychosis and paranoia.
Clinically, withdrawal symptoms can mimic psychiatric disorders, which complicates diagnoses and treatment.
Behavioral effects include agitation, anxiety, and sleep disturbances. Treatment is mainly supportive, with benzodiazepines used for agitation.
There's some experimental use of modafinil and stimulants like methylphenidate, but success is limited.
The cocaine crash is like a brutal physical and psychological reset that punishes the user and drives relapse. It's a tough cycle to break.
Absolutely. Now, moving into the psychological models that underpin behavior change, the Trans-Theoretical Model of Change, or TTM, is foundational.
TTM outlines 6 stages: pre-contemplation, contemplation, preparation, action, maintenance, and termination.
In pre-contemplation, patients are unaware or unwilling to change, historically called denial, but now reframed as true unawareness.
Then in contemplation, patients experience ambivalence, weighing pros and cons, often fearful of change.
Preparation involves commitment and planning steps toward change, though ambivalence may still linger.
Action is when active behavior change occurs, with problem-solving and restructuring cues and triggers.
Maintenance focuses on consolidating gains and preventing relapse, while termination represents sustained change with low relapse risk.
Clinically, recognizing the patient's stage allows nurses to tailor interventions appropriately. For example, validating lack of readiness in pre-contemplation or supporting ambivalence in contemplation.
Motivational interviewing, or MI, complements TTM perfectly. It's a patient-centered, directive counseling style to enhance intrinsic motivation.
MI emphasizes empathy, avoids confrontation, and explores ambivalence. It uses cognitive dissonance by highlighting discrepancies between behavior and goals.
The 8 steps of MI include establishing rapport, setting the agenda, assessing readiness, sharpening focus, identifying ambivalence, eliciting self-motivating statements, handling resistance, and shifting focus.
What's key is that motivation is seen as interpersonal, not just individual. Resistance is normal, and rolling with resistance avoids power struggles.
Self-motivating statements from patients are stronger drivers of change than external advice.
The dialogues in the document, like with Eliza and Kang, illustrate therapeutic leverage and managing resistance beautifully.
Yes, like when the nurse validates Eliza's feelings and uses silence effectively, or when the nurse gently challenges Kang's denial while respecting his perspective.
MI is more like a dance than a lecture, skillful, responsive, and patient-centered.
Now shifting gears to harm reduction, which represents a pragmatic shift away from abstinence-only models.
Harm reduction is both a philosophy and practice, emphasizing the intrinsic value of all humans, non-judgmental and non-coercive services, and empowering users to make choices.
Key programs include needle exchange to reduce blood-borne infections, opioid substitution therapy with methadone or Suboxone, heroin-assisted treatment for those not responding to standard therapies, supervised consumption sites, and managed alcohol programs.
Heroin-assisted treatment is controversial, but shows improved health and social outcomes for some patients.
Supervised consumption sites provide safe environments for drug use with medical supervision, reducing overdose deaths and public nuisance.
Managed alcohol programs offer controlled alcohol doses to chronically homeless individuals with alcohol misuse, reducing binge drinking and non-beverage alcohol use.
Harm reduction reduces mortality and morbidity, even if abstinence isn't achieved, and supports engagement with hard-to-reach populations.
It requires non-judgmental attitudes from healthcare providers, which can be challenging but is essential.
The shift from moralistic to pragmatic care is profound and necessary.
Speaking of attitudes, the therapeutic nurse-patient relationship is foundational in addiction care.
Absolutely. It's a goal-directed creative process involving consistency, pacing, listening, positive regard, and genuineness.
Peplow's 4 phases, pre-orientation, orientation, working, and termination, guide the relationship's evolution.
Empathy is critical. Understanding the patient's perspective without losing objectivity, unlike sympathy, which can cloud judgment.
Boundaries protect both patient and nurse, and awareness of transference and countertransference is important.
Communication techniques like effective use of silence, validating feelings, avoiding power struggles, and using open-ended questions enhance the relationship.
The Elise and Kang dialogues are great examples of therapeutic leverage and managing resistance.
Now, on a different note, let's discuss oppositional defiant disorder, or ODD, which often comes up in pediatric and adolescent settings.
ODD is characterized by a persistent pattern of angry or irritable mood, argumentative or defiant behavior, and vindictiveness lasting at least 6 months.
Core symptoms include losing temper, being easily annoyed, arguing with adults, refusing to follow rules, deliberately annoying others, blaming others, seeking revenge, and holding grudges.
Risk factors span biological, psychological, and environmental domains. Family history of ADHD or mood disorders, poor emotional regulation, inconsistent discipline, family conflict, abuse, and poverty.
Differentiating ODD from normal childhood behavior involves frequency, persistence, and impairment.
And it's important to distinguish ODD from ADHD. ODD involves defiance and hostility, while ADHD involves inattention and hyperactivity.
Also, ODD differs from conduct disorder, which involves serious violations of others, rights like aggression, theft, or fire setting.
Nursing interventions focus on consistency, clear expectations, consistent consequences, predictable routines.
Limit setting with choices helps avoid power struggles. For example, instead of saying stop being difficult, say you may choose to complete the assignment now or during free time.
Positive reinforcement is key, focusing on successes rather than failures.
Parent teaching includes consistent discipline, rewarding positive behavior, setting realistic expectations, avoiding yelling, and modeling emotional control.
Therapeutic communication avoids direct confrontation and reflects feelings instead, like responding to "you're not the boss of me" with "you seem upset." Let's talk about what is bothering you.
Finally, let's cover suicide risk assessment and nursing care, which is critical in mental health and addiction settings.
Suicide is the act of ending one's own life. Suicidal attempts result in survival, while ideations are thoughts about suicide.
Neurobiologically, imbalances in serotonergic, dopaminergic, and noradrenergic systems, low cerebrospinal fluid levels of serotonin metabolites, and dysregulation of the stress response system are implicated.
The sad person's mnemonic helps remember risk factors: sex, age, depression, previous attempts, excessive alcohol, rational thinking loss, sickness, organized plan, no social support, and stated future intent.
Protective factors include internal ones like coping skills, frustration tolerance, sense of purpose, and religious beliefs, and external ones like social support, access to healthcare, responsibility to others, and restricted access to lethal means.
Clinical manifestations vary but often include social isolation, mood swings, talk of death, changes in sleep or eating, and high-risk behaviors.
Screening tools like SAFETY, the Columbia Suicide Severity Rating Scale, and the Patient Health Questionnaire 9 assist in assessment.
Nursing care priorities are thorough risk assessment, removing harmful items, instituting one-to-one observation, maintaining a non-judgmental and caring attitude, collaborating with the interdisciplinary team, and developing safety and support plans.
Client and family teaching focuses on recognizing triggers, sharing safety plans, medication adherence, counseling, and knowing emergency resources.
It's a complex, sensitive area, but absolutely vital.
So to wrap up, addiction care is a complex interplay of biological, psychological, social, and cultural factors.
Effective screening, assessment, and treatment require both objective tools and nuanced interpersonal skills.
Harm reduction and motivational approaches represent a paradigm shift toward compassionate, evidence-based care.
And nurses play a pivotal role in bridging clinical science and human connection to support recovery.
Well said. That's a lot to think about, but it's encouraging to see how far addiction care has come.
Definitely. It's about meeting patients where they are and walking alongside them, not just telling them what to do.
Exactly. Thanks for exploring this with me.
Thank you. Until next time.